I was a nurse for almost 40 years and thought I was 10 feet tall and bulletproof until the day that I was diagnosed with B-cell lymphoma. He told me that what I had was treatable, curable, and that being said, I wasn't going to like what he did to me. And that's true, I didn't, but I liked the outcome.
6 years ago, I was diagnosed with breast cancer, went through a mastectomy, had chemotherapy. This past June, I was diagnosed with recurrent breast cancer. You felt great, and then suddenly you're diagnosed with cancer. And it's this huge thing that just hits and your life stops. It's like everything focuses on that, and the rest of your life just went on hold.
When your oncologist first meets with you, they'll talk with you about your diagnosis. They'll review all of the imaging and all of the evaluation that you've had prior to that visit. One of the most important parts of a new cancer diagnosis is determining the stage of the cancer, and stage is important for prognosis as well as for determining the type of treatment that's required. So staging process sometimes includes biopsies, it sometimes includes additional scans or blood work. Once the staging is complete, your doctor will determine the type of treatment that's required, and that may include chemotherapy or radiation or surgery, or sometimes a combination of 2 or 3 of those options.
Turns out my veins were fine, but my lymph nodes were enlarged. So the cancer had come back and it was in my lymph nodes this time. I had surgery to remove those lymph nodes, and I'm currently undergoing chemotherapy. I will follow that with radiation therapy later this year.
Chemotherapy works by attacking dividing cells. Cancer cells tend to divide more quickly or more rapidly than our normal cells, so the chemotherapy preferentially attacks those cells. As a systemic therapy, that means that it goes into the bloodstream and goes all over the body, and it can fight cancer cells no matter where they are. Chemotherapy can treat a cancer that's currently in your body, or even if you've had surgery and the cancer's been removed, it can help kill off any extra cancer cells that could still be there in order to prevent recurrence. When chemotherapy is given after surgery, that's typically for curative purposes. In this case, chemotherapy is called adjuvant therapy, and the chemotherapy is given in order to kill off any cancer cells that could have been left behind after the surgery.
Thinking of going through it again was daunting. And if I had a chance to vote, I would have voted no. Let's not do this again.
Chemotherapy is given in cycles. Each cycle is 2 to 4 weeks in length. During a cycle of chemotherapy, you may come in 5 days in a row, you may come in once a week for treatments. It depends on the particular cycle and the particular drugs that are being given.
I feel as a medical assistant I have one of the best roles in the office because I get to follow our patients through the whole course of their treatment. We start by rooming the patients for the providers. We take their vitals. We refill prescriptions for them, hear all of their concerns, their family's concerns, do lab draws, injections. We do a wide variety of things for patients and their families.
IV chemotherapies can be given through a peripheral vein, or sometimes we recommend that you have a port or central line placed for chemotherapy. That's sometimes a safer option depending on the type of drug that's being used. A port is a small catheter that goes under the skin, right under the collarbone, and it can be accessed directly through the skin with a needle. When you have a port placed, you can still shower and swim and do everything that you would normally do. Most patients don't even notice them after a little while.
Where I've been going, we've got recliners, and they're all sort of in 2 half circles, and people come in, you pick your recliner, sit down, and then the nurses usually see you right away, come over, greet you, and then start you with the process of accessing your port or starting an IV, and then they'll start the different medications. Most of the time, they will use what's called a pre-medication that keeps you from getting nauseous and some fluids, and then they'll actually start the chemotherapy.
We'll introduce ourselves, then we will access either their port or start an IV, and then We will talk about their chemo medications. We provide printed information about all of their chemo medications. We go over their standard consent form. And basically what the standard consent form is, a review of the side effects that are listed in the printed information. I like to get the IV started before we talk about that because that seems to be an area of anxiety for people. So I like to get that out of the way and then we move on with the education so that you can really relax and focus on what we're talking about.
When you go into the infusion room, there are people in some of the chairs already. Some people are snoozing, they're taking little naps. Those pre-medications make you a little sleepy. So some people just take that time to take a nap. Others will be reading, some might be knitting or crocheting. There's a lady that's got almost a full blanket now because she's been there a while. As a rule, you sit down, usually whoever's sitting next to you greets you. They have coffee and tea. They have usually some snacks and drinks.
And it became a comforting place to come to and receive the support of the staff as well as the other patients.
There's a camaraderie that develops. It's, I think, almost like a wartime relationship, that you're in something hard, you're in the trenches together, and you have these instant relationships with folks. I've made some friends.
And the other part of that was being able to give to people that were coming in. As I became more senior as a patient and had more understanding of what was going on with myself and my situation and other people's situation, there were new people coming in every time, you know, with that deer in the headlight look. What's going to happen to me? You know, the fear of the unknown, the fear of having cancer, the fear of chemotherapy. And I think as a community, staff and patients, it was comforting for me, and I was able to comfort people as they came, and I could see that.
They call your name, you go in, you change into your gown or whatever, and you're alone in there. Or if they're going to draw your blood, there's kind of an aloneness there. So I would just encourage you to, you know, use your friends and family for support. Bring people around you. There's sometimes a sense of wanting to sort of back away from it and just sort of, well, I'll just tough this out. But I think you really need people during this time. It's an important time to let people help you because they really want to.
As a naturopathic physician, I treat patients with nutrition, supplementation, and herbal medicine. I may be able to help you during your cancer care by decreasing side effects of chemotherapy, promoting your overall quality of life, and even longer survival. Typically, you would see me before chemo starts, during chemotherapy to reduce side effects, and after chemotherapy for a reoccurrence prevention plan. I want you to leave our clinic feeling you know how to take care of yourself and any supplements that may benefit in the long term to prevent cancer recurrence.
Because chemotherapy affects dividing cells, it sometimes affects normal cells too. Those effects are more commonly seen in the mouth and GI tract, sometimes in the skin, sometimes in the hair follicles, and that can cause hair loss.
Every time someone has chemo, they're going to have a reaction, but nobody knows what that reaction is. My questions were, am I going to lose my hair? Their response was, I don't know. I did lose my hair. Some people don't.
Sometimes the hair actually growing back and it's a better hair. It can be darker, it can be lighter, it can be curlier or less curly. We just never know. Sometimes the patients have a pleasant surprise after the chemotherapy is done.
The first time I went through chemotherapy, I did not lose my hair. It got thinner, but I had it the whole time. This time, as you can see, it's gone. And I was surprised because at first, when it's starting to come out, your head hurts. It's like it's bruised when you're combing it. Once all the hair's gone, it doesn't hurt at all. So if you're at that stage where it's just starting to come out, it will get better. It's not going to hurt later. That was a surprise to me. Now I have a little tip for you. Once you decide, okay, I'm just going to go ahead and shave it off. A lot of us do that, just instead of waiting for it all to fall out. You still have little tiny hairs up there. If you use a lint roller, I know it's funny, but you just roll that on there and you can pull the rest of those little hairs out. I've been having a great time trying out different scarves. I haven't been using wigs so much as I have hair extensions. You can get parts of hair and put on a scarf and then clip it. I have dreadlocks. I come to the infusion clinic with a different style every time.
For the next week, I was so fatigued that about 2:30 in the afternoon, I'd curl up in the corner and take a nap.
It's interesting how tired you can get and how crummy you can feel. Sometimes you wonder if I'm not doing it well. I'm not really very good at chemo because I'm having all these side effects.
In reality, we never really know how an individual patient will react to any individual treatment that we prescribe for that specific patient. We are all different, and before giving a chemotherapy to any patients, for example, we would never know if that patient developed an allergic reaction. It's very typical for all of our patients that they receive some strong anti-allergy medications before giving the chemotherapy.
My initial experience with that unpleasant effect is the fact that I have asthma, and one of the medications that I was on was Rituxan. So the first time I had chemotherapy, they put me on Rituxan. I'm sitting there and I started to have an asthma attack. I started to have difficulty breathing and I started to panic. I said, I'm having an asthma attack. And the nurse's response was, oh, good. Now, I've had asthma for many years and I've never had a good asthma attack, and I've never had anybody say, oh, good. I said, what do you mean, oh, good? And she said, that means that your body is setting up antibodies that are attacking the cancer cells. So I said, oh, good. They gave me some medicine to counteract the allergic type reaction that I was having, and I felt better. The thing that I gleaned from that was that as my body changed as a result of the chemo agents, I needed to keep the staff informed of where I was at and what was going on with me.
Sometimes medications can be prescribed to help manage side effects such as nausea. We typically give anti-nausea medications before the chemotherapy infusions, and your doctor may recommend that you take some of these medications at home to help manage nausea or other side effects at home.
But we have some great anti-nausea medications on the market now, and so our goal really is for you to have, for any patients to have a nausea-free experience. And so that's something, if you have any nausea at all, you need to talk to us about, because we really, our goal is to minimize that as much as possible. Another one of the side effects are like some skin changes. You may or may not lose your fingernails. We just have people keep their fingernails short and clean. And then there might be some bowel changes too.
Typical side effect with many chemotherapy treatments is diarrhea. We also have good oral medications that we can treat that.
Another common side effect that may or may not happen are mouth sores. But we have you start on a really good mouth care protocol right at the very beginning of your chemotherapy, and that's for all chemotherapies.
We also monitor the kidneys and the liver function, because most chemotherapies are metabolized through the liver or the kidneys. We need to make sure that these organs are functioning normally during your treatment to make sure that the treatments are safe and that you're not having any serious side effects. Since chemotherapy affects the bone marrow, we need to make sure that these blood levels are normal before each dose of chemotherapy. Sometimes a dose may have to be held or lowered because of the low blood counts.
Probably the most serious side effect in the view of medical oncologists are patients whose immune system is damaged by the chemotherapy and they have an overwhelming infection. The easiest way to deal with this actually is prevention. So we monitor your blood counts, and if it's very low, we put you on antibiotics. We give you an injection that can boost your bone marrow and can produce more white blood cells.
There are supplements and herbs that can decrease side effects, such as preventing peripheral neuropathy as much as we can, helping with weight maintenance, and promoting healthy appetite, and helping you cope with any digestive changes that come along.
If you notice something that's different or unusual for you, it's important for patients to contact our office, and our office number is a 24-hour number.
Your doctor may recommend a CT scan or a PET CT scan to follow your cancer. A CT scan takes a black and white picture of your internal organs and your bones. A PET scan actually measures the functional activity of the cells in your body. You receive a radioactive glucose injection prior to the PET scan. Cancer cells are more active than the cells around them, so they tend to use more of this radioactive sugar. On the PET scan, they light up on the scan, and we can more easily distinguish cancer cells from normal cells on a PET scan. Depending on the type of cancer you have, your doctor will recommend one of these types of images.
Cancer clinical trials are research trials where we are working to find new treatments for cancer prevention, or the symptoms that are caused from your cancer treatment. There are different phases of trials that start with how they're going to give the drug, all the way to things that are already being used that we're going to use for a different indication. And the most important thing to remember is that if your doctor recommends that you be on a clinical trial, you're not a guinea pig. And you always have the option to say no. It's not going to affect how we treat you or your care. And if you do say you want to participate in a clinical trial, you always have the option to say no, even if you are a day into it or a year into it. We still want to follow you and gather your information as you go through your cancer journey, because everything that you offer is helping someone else down the line.
We have a lot of other opportunities and a lot of people who have jobs, especially to help patients get the resources that they need.
Cancer is universal, but the experience is unique to every individual. Some people living with cancer can walk through the experience unfazed, and then there are others that have fears at every twist and turn. I'm here for everybody, whether it's just to touch base on how you're doing with your treatment that day, or if your treatment's over and you get to that point of saying, now what? With oncology counseling, it's really about just talking through the feelings you're experiencing on this new journey. I work with families, couples, and individuals. Cancer affects everyone. Sometimes people come to me just to find out how to deal with all those phone calls that they've been getting due to their new diagnosis. I also help patients with guiding them through stress-reducing techniques. My favorite part of the job is getting to know people on a really deep personal level, and most of all, getting to help.
I probably have one of the most rewarding jobs in this organization, because I'm able to ease people's minds by giving them the financial information that they need so that they can not have surprises, not go into this worried that they're going to lose everything, but more or less just to sit down and look at your situation and see what you have and what we can do to help you. I have a good reason to be biased towards this office, to the clinical staff, to the physicians, to the office staff. The reason is that I am a cancer survivor myself, and I wouldn't want to be anywhere else but here with the people that are here taking care of me.
A lot of patients who say that they are so lucky to have us, but really I feel that we are blessed to have this population of patients.
Here in Kalispell, I have had excellent care.
My last chemo, at the end of it, there was a big celebration with bells ringing, and it was as important to them to see me walk out that door as it was for me to walk out that door.
I like the unique relationship that cancer patients have with their physicians, and I like being able to allow my patients to take part in decision making about their care, and I think as a cancer patient that's an important thing to do.
I recently read a quote that said, "You've got to live, even if it kills you. And I think the chemotherapy is a lot like that. You know, it is going to give you life. It's the light at the end of the tunnel is when you finish chemotherapy, and it is doable. Chemotherapy, the treatment, the radiation, that stuff is all doable. Even though at the time it may make you feel sick or tired, you're going to get through that. And there are going to be good days again. And your life that was on hold for all this, you're going to take off again. And the joy is going to be back.
But I got steadily stronger, and 3.5 months after finishing my chemotherapy, I went in at 9,000 feet, 6 miles, and killed a 6-point bull elk with my bow. I never thought I'd do it again. I stood at 9,000 feet on a beautiful evening and cried like a baby. It was important at that point in my life to realize that my life could go on, and it had gone on, since that was one of the things that I had done most of my life, is hunted and fished, and I'm still able to do that.